let's move on to the next talk on how Spain achieved a remarkably high rate of deceased organ donation. May I invite the speaker, Dr. Beatriz Dominguez Gill. I now invite the chairpersons to chair this talk, Dr. Marty Manuelich, Dr. Himanshu Patel, and Professor Vivek Ute. Over to the chairpersons.
So Marty, please introduce.
Yes, my pleasure to be the chairman together with you. And my pleasure to introduce my colleague and friend, Beatriz Dominguez. She's a nephrologist by training for many years. And also he has been very active in the donation development in Spain together with our previous director, Dr. Mate Sanz. For the last year, he's the director of the ONT, is the leader in the country. He did many publications, and also I can share with you that he's passionate for this kind of donor that we call DCD. Then it's my pleasure to introduce today Beatriz Dominguez, and maybe for the questions yourself, my co-chairs can do the questions. Thank you.
Thank you very much, Marty. Can you confirm that you can see my presentation and you can hear me well?
Yes, okay. Hearing you, and we see the presentation.
Okay, so thank you very much for your kind introduction, and thank you very much to the organizers for inviting me to participate in this excellent annual conference of the Indian Society of Organ Transplantation. In the next few minutes, I will try to summarize how we managed in Spain to achieve very high rates of disease donation. So in 2010, the World Health Organization organized a global consultation on donation and transplantation in the city of Madrid, Spain. And a product of this consultation was what we call the Madrid Resolution on this topic, by which professionals and governments were called to pursue self-sufficiency in transplantation. It was very clearly stated that the priority source of organs for transplantation should be not live donors, but deceased organ donors, and that deceased donation should not only be maximized, but be made possible whether an individual was declared dead by neurological or by circulatory criteria. So we have been called to maximize deceased donation because of the patient needs. But there is a new paradigm in organ donation, which emerges from the progressively more accepted concept that decision-making at the end of life should not only be based on medical aspects, but also take into account moral, societal, and welfare considerations. And within this framework, there is an increasing number of professional societies in intensive care, and very recently also the World Medical Association stating as a professional standard that donation should be a routine component in the end-of-life care, which means that when a patient dies or is about to die in conditions consistent with organ donation, the treating team should pose the option of organ donation and make it happen if it was consistent with the wishes and the values of the individual, and not because of patients on the waiting list who for sure are the leitmotif of organ donation, but also for the overall best interest of the dying patient. In Spain, we have implemented these two principles in a very good manner, in a very good way. Here you see the evolution of deceased donation in our country. The columns represent the number of deceased organ donors, and the circles represent the rate of deceased donors per million population. So ONT was created in 1989 as an agency depending on the Ministry of Health in charge of organizing donation and transplantation activities in our country. This is important because transplantation and donation was placed in the political agenda, and somehow it made the government be accountable for donation and transplantation practices as well. We had to work in a country which already had a transplant law, of course, the technical capacity to perform transplantation, and transplantation is performed within a public healthcare system that ensures universal access to transplantation. We agreed upon with the 17 regions in the country a model of coordination that led our country evolve from 14 to more than 30 donors per million inhabitants in this first period. We had a second period of apparent stabilization of the activity in coincidence with a decline in the pool of DVD donors, as you will see afterwards. And then we have a third period of further increase of disease donation in coincidence with the implementation of a set of innovative strategies. Then we had COVID, and we are dealing now with COVID. But in my presentation, I'm going to focus upon some of the elements of this first phase and some of the elements of this third phase. just for you to understand what we were able to achieve, if we look back to our record year, which was 2019, we registered more than 2,300 donors, 49 per million population, which is really very high disease donation rates compared to any other large country throughout the world. So before we go into the elements of the Spanish system, I would like to clarify the issue of presumed consent or opt-out system in Spain. We do have a presumed consent policy in Spain since the year 1979, when our legislation was issued. And it clearly states that every individual who dies in Spain will be an organ donor unless they have expressed the opposite during lifetime. There are positive things about having a presumed consent policy, because the message that is launched to the population is that the normal thing to do is to donate. But if strictly applied, the public opinion may have the negative perception that the state is the owner of the organs, where the views of individuals and relatives are not taken into account. So we have never strictly applied the presumed consent policy. The procedure that we followed is detailed in secondary legislation. The donor coordinators need to check, among others, the Advanced Directives Registry, which allows individuals to register as organ donors or non-organ donors. This information is taken to the relatives to confirm that donation was consistent with the wishes and the values of their loved one. But if the family says no, we will not proceed with organ recovery. So exactly as it happens in any country with an opt-in system. If we have to summarize the first phase of our increase in disease donation rates, we would use the word management or organization. The key for success is the appropriate organization of a process of high complexity, which is the process of donation after death. Here you have the DVD pathway. We could represent the DCD pathway. But of the different phases of this complex process, the key one is the identification of persons who die or are about to die in conditions consistent with organ donation, who are very few. In Spain, we estimate that only 1 to 2% of hospital deaths die in conditions consistent with organ donation. So we need a system well organized to systematically and routinely identify these exceptional circumstances of death, and then to orchestrate this process in a manner that there is a smooth transition from possible to actual and utilize the deceased organ donor. So the key word is management or organization. These are the elements of the Spanish system, the Spanish model, that have been well described in the literature. In the interest of time, I'm just going to focus upon 3 of them. First of all, and as Dr. Maria Paula Gomez was previously stated, we have placed the intensivist in the midst of this complex process. Intensivists are the ones who are going to orchestrate this, because intensivists work precisely in those units where donation opportunities are going to be emerging. And if I had to select one element of the Spanish system, I would select this one. We have at present 185 hospitals authorized for organ donation in the country, and in each one of these hospitals, we have a donor transplant coordination unit. These units are always led by physicians and mostly by intensive care doctors. So you can see how 63% of our donor transplant coordinators are physicians, and how more than 80% are intensive care doctors, and the rest are basically anesthesiologists or emergency care physicians. So there is an important presence of the critical care community in the donor coordination factor, and this is definitely a key for success. The second element that I want to highlight is that we have established a way of coordinating coordinators. So donation happens in the hospital, but the disease donation pathway is supported at the national level by ONT, and in each one of our regions by a regional donor transplant coordination unit. This regional and national level that work in very tight cooperation to have common policies in donation and transplantation around the country support the development of the disease donation pathway in the hospital by designating coordinators, ensuring that they are continuously trained, that they are provided with common protocols, recommendations, and guidance, and that performance in disease donation is continuously evaluated. Remember that without data, you cannot assess performance in disease donation. So we continuously audit what happens in the hospitals in the disease donation pathway. And also remember the Hawthorne effect. everyone who feels observed automatically changes their behavior. And the third element that I want to stress, and that Dr. Gomez has stressed previously as well, is the relevance that we have given in our country to training. So we ensure continuous training of donor transplant coordinators and of all professionals, healthcare professionals and non-healthcare professionals who directly or indirectly participate in the process of donation. It's important to say that this continuous training is covered with governmental funds. So one of the sections of ONT's budget is devoted to training. We make every year a call for proposals, so different hospitals, institutions, and units can apply in order to provide training to all these professionals aligned with the key priorities that are established by ONT. We devote every year 1 million euros to train our professionals. But if I had to now move to the third phase that I was describing before, where we were able to further increase the donation rates, I would use the word innovation. And innovation was absolutely needed. And just keep this in your mind continuously. We continuously need to innovate. We needed it because the incidence of brain death was declining in our country since the beginning of the century, though it has in the last year stabilized. And this was due to the fact that there has been a reduction in events leading to devastating brain injury, improvements in neurocritical care, changes in neurocritical care. So, for example, the compressive craniectomies are very frequently performed at present, and changes in end-of-life care. So we have a high number of individuals who are not dying in a brain death condition in our ICUs, but are dying following devastation through life-sustaining therapies. And our possible organ donors are getting older and older. So you can see here how their median age at present is 63 years, and most of them have died because of natural causes, cardiovascular, cerebrovascular accidents, or anoxic encephalopathy. We have very few possible organ donors who have died as a result of trauma. So with this change in the scenario, we needed to do things in a different manner. Over the years, we have been developing different strategic plans in order to further confront this changing environment. And at present, we are in the midst of what we call the 50-22 plan, which aspires to achieve 50 donors per million inhabitants in the year 2022. Unfortunately, we would have achieved this rate in 2020 if COVID-19 had not visited us, but we are still working to achieve this objective. The plan is focused upon, or is based on 6 different pillars, but in the interest of time, I'm just going to talk about 3 of them. The first of those pillars is the use of expanded criteria donors. Well, we didn't have any option. Our possible organ donors are old or very old individuals, so the system has fully adapted to that profile. So you can see how at present, more than 50% of our donors are 60 years or older, about 30% are 70 years or older, and depending on the years, between 5 and 10% of our donors are 80 years or older. So we have adapted to the type of possible organ donors that we have, that of course are allocated to old recipients who have shorter expectancies of survival. Because of course the question that you have in mind is that these organs poorly. And of course, organs from old individuals do worse than organs from young individuals. We know all that already, but that's not the sort of comparison that we should be doing. This is a study that was recently published in which we evaluated the survival of recipients over the age of 60 years who had received a kidney transplant from a donor over the age of 60 years compared to their counterparts who remained on the waiting list. Here you have represented the relative risk of death. This is the reference, patients who remained on dialysis and who were matched by a number of variables with patients who received a transplant. And you can see how the relative risk of death at 12 months was significantly lower when you received an old kidney than when you remained on dialysis. And this reduced relative risk of death at 12 months was so when the donor was aged between 60 and 80 years, but also when the donor was 80 years or older. So our comparison is not whether these kidneys work better or worse than young kidneys. We know that they work worse, but we should also be comparing with, we should always be comparing with remaining on the waiting list. What are the alternatives? The second pillar is DCD, donation after the circulatory termination of death. So in Spain, in light blue, we have been developing for many years uncontrolled DCD, donation from persons who suffer a sudden cardiac arrest that cannot be successfully resuscitated. But what has been particularly important in our country over the last few years is the development of controlled DCD in dark blue. Controlled DCD refers to donation from persons who die following the session to withdraw life-sustaining therapies that are no longer deemed beneficial to the patient. This program was piloted in 2009. The regulatory framework was developed in 2012. And you can see how even in a very complex year as 2020 was, we were able to record 603 controlled DCD donors. We have been able to achieve the higher levels of DCD per million population in the world. And right now, 1 out of 3 donors in Spain is a DCD donor. Besides, we have managed to make DCD be a multi-organ recovery procedure. So we are not only successfully using kidneys from DCD donors, but we are using livers, lungs, pancreas, and hearts. We initiated in 2020 our heart DCD transplant program, and so far we have developed 11 procedures of this kind. Well, to do so, we had to confront our worst enemy in DCD, which is organ viability, post-transplant outcomes, particularly in the liver setting. This is an explanted DCD graft where you can see there are a huge number of intrahepatic abscesses in the context of ischemic cholangiopathy. This is our worst enemy in DCD. So if we wanted to transform DCD in a multi-organ recovery procedure, we needed to ensure appropriate post-transplant outcomes of all organs. So in Spain, we have been proceeding what we call normothermic regional perfusion. This consists in the perfusion of organs that are going to be used for transplantation with oxygenated blood by use of an ECMO device after the determination of death and prior to organ recovery, because this allows us to regenerate ischemically damaged tissue. It transformed the recovery procedure into a calm elective procedure, very similar to DBD, and it allows us to evaluate organ viability prior to transplantation. So here you see a very large cohort of controlled DCD livers, 258 recovered by the standard rapid recovery technique, which is used in the majority of countries with a DCD program, with 545 livers obtained with normothermic regional perfusion. Already in the univariate analysis, you can see how patient survival and graft survival is significantly better when we use NRP compared with rapid recovery. And here in the multivariate analysis, you can see that with NRP, we are able to significantly decrease the risk of early allograft dysfunction, primary non-function, hepatic artery thrombosis, all type of biliary complications, ITBL, retransplantation, graft loss, and patient death. So we've been able to prove that NRP is really able to transform the results of controlled DCD livers and make them comparable to the results that we obtained with DBD livers. And as most of you are nephrologists, we have also been able to show benefits in terms of kidney transplantation. So with the use of NRP, we've been able to significantly decrease the risk of delayed graft function and 1-year graft loss compared with a rapid recovery technique. To finalize, I want to refer to a practice that has been critical to improve this estimation in Spain, what we call intensive care to facilitate organ donation. This is not a new practice. This is an old practice in Spain and in other countries throughout the world, but we decided to give it a name which highlights the word care, because this is a process in which the care of the dying patient remains paramount. And we gave it a name, for the sake of transparency with other professionals and transparency with the family. So we defined ISOT in Spain as the initiation or continuation of intensive care measures like ventilation, in patients with a devastating brain injury in whom these measures would not be applied with a therapeutic purpose in order to incorporate the option of organ donation into their end-of-life care plans, to allow these individuals who are going to die to do so in circumstances that make organ donation possible. In order to promote this concept, we have been working with the Emergency Care and Intensive Care Society in Spain. We have developed very critical guidelines for ensuring best practices in this complex process, and we have provided training in this particular concept to thousands of emergency care and intensive care professionals along the years. So the result is reflected in the study that we published a few years ago, in which we describe the circumstances of death of patients who died as a result of a devastating brain injury in Spanish hospitals. 10% of these patients had been admitted to the ICU just to be organ donors, and they contributed to 24% actual deceased donation in the country, which means that in Spain, we would never have been able to achieve those high levels of deceased donation without the routine consideration of the possibility of admitting a person into the intensive care unit with no therapeutic indication just to enable organ donation to happen. I'm very aware that many of these measures may not be feasible in India, but I think some of the fundamental concepts are important for India as well. And I'm also aware that some of these initiatives may be shocking even for some of you. But I always remember this sentence from Albert Einstein, who used to say that insanity is doing the same thing over and over again and expecting different results. If we want to change our reality, we definitely need to think in a different manner. Thank you for your attention.
Thank you, Professor Beatriz, for very comprehensive presentation of your experience, and of course, Spain is leader in disease donation worldwide. Whether the COVID vaccination complete schedule is mandatory while on waiting list before deceased donor transplant?
You mean the COVID-19 vaccine?
Yes, yes.
So it's not mandatory. We have not established a specific calendar for the vaccination of patients on the waiting list prior to being listed or prior to being transplanted. The only thing is that they have had priority in the vaccination scheme in Spain, and they are now receiving the third dose of RNA M-based COVID-19 vaccines. But we don't make it mandatory to have the vaccination complete prior to being waitlisted.
What will be your suggestion to prepare for the third wave of COVID-19?
To prepare for, I'm sorry?
To prepare for the third wave of COVID-19.
To prepare for COVID-19?
Third wave.
To us, it has been very challenging to confront the COVID-19 pandemic in terms of disease donation and life donation transplantation activities because the COVID-19 pandemic imposes very different obstacles to the development of the process. We saw a very important reduction in the pool of donors. We had to manage fear of professionals not being sure that it was appropriate to proceed with transplantation in a moment of sustained virological transmission, especially when COVID-19 free pathways had not been well established in the country. We also had positive donors for COVID-19, positive recipients, and a huge amount of problems with professionals. I would say that even one of the strengths of the system in Spain, which is to have intensive care doctors engaged in disease donation, was a little bit of a weakness during the COVID-19 pandemic because all these professionals were taken to take care of COVID-19 critically ill patients. And we had to overcome all these obstacles. The decline in disease donation and life donation in 2020 was very important, 23 and 26% respectively. We are progressively recovering this year, but it's still a very complex year. And in terms of management of patients, as I told you, we don't require complete vaccination, but I can tell you that most of our patients on the waiting list have been vaccinated already, as well as our transplant recipients are receiving the third dose, even the third dose. And to us, it has also been very critical to convince our government to show them results of the impact of COVID-19 into the transplant patient in Spain. We've been able to make evident the very important impact in terms of severity of the disease in this patient population, particularly kidney and lung recipients.
Thank you. Over to Dr. Marty. Sir, you are muted. Dr.
Marty, you're muted.
Of course. Well, I think it's a very nice presentation. We know everything also in Spain and all these points. And Beatriz, you have to have one recommendation for India, how or where to start. What will be your main recommendation? Because it's a big problem between the public hospitals who have out of resources and limitation and on time and experts, and also there's a private center who have the possibility, no? But all the country, some regions start, mainly as Vivek could explain, in the south of the country, but still the rest of the country is pending, no? Then you have to recommend something today for India. What will be your advice, Beatriz?
Well, it's very challenging, the situation in India, of course. A very important recommendation, in my view, would be the engagement of the intensive care community. So I would like to, I would envision a system in India in which in every state and in every region and in every of your hospitals, you have a key individual, an intensive care doctor. It doesn't have to be the system in Spain. It may be a reference individual in intensive care who is a donation physician, who is a leader in this field, and who promotes education of their colleagues in critical care, who is in charge of education and of training, and in charge of the development of protocols and procedures at a center, regional, and national level. So I think a network of intensive care doctors under the framework of NOTOS, SOTOS, and ROTOS in India would definitely be very important. It would be great if these individuals could be trained as trainers, so they are able to spread all the knowledge and the training and develop their own training strategies in the country. To me, that would be a very important first step. A second very difficult issue is the field of having transplantation occur in the private sector. In Spain, it's completely the opposite. We don't have private centers doing transplantation. We have very limited exceptions, and most of the transplants are performed in the public sector. And this gives us a lot of strength because, you know, the public, all the population has equal access to transplantation, regardless of their social and economical situation. If I think this was mentioned by Dr. Vivek Jha before, I think it would be very important to convince the politicians, the governments, that if you are investing in dialysis, it is well justified to invest in transplantation and to start to develop transplantation programs in the public system as well. And of course, the private sector should be committed to this donation as well. If you have a transplant program, you should be able to make this donation happen also. Well, I'm looking forward to visit India and know India in person, but from what I know from your system, in principle, this would be my main two recommendations.
Yes, madam, we will welcome you. Dr. Agarwal, you want to say something? You are muted, sir.
Yeah, in terms of renal transplant during COVID infection, actually it is a demand and supply which has affected. We in a public sector hospital at the expense of a non-COVID, at the expense of a COVID patient, we cannot go on doing elective surgery for the non-COVID. In terms of an overall transplant in the country, I think that too, I'm involved with the NOTO for last 10 years or so. One major problem in our country is that the policymaker and the professionals are not on same page. And that makes, in spite of ROTO, SOTO and NOTO being there, and the rules are there, guidelines are there, these are not implemented in a letter and spirit. And that makes the system inefficient in terms of improving the organ donation.
Well, absolutely. Well, I think it is really critical that the principles of making this donation possible and investing in kidney transplantation when there is investment in dialysis should be clearly exposed to politicians and governments, so priority is given to the development of solid transplant programs. And I think this should be feasible in India. And regarding the reference to COVID, of course, most countries were overwhelmed with the COVID-19 surges, so elective surgeries had to be stopped. In life transplantation, of course, you can postpone the procedure. In disease donation, we need to admit that if we don't proceed with organ transplantation, this is a lost opportunity. That opportunity will never come back. So what we have instructed our centers to, of course, if they are in a critical situation on a center-by-center basis, if they are in a critical situation, they should give priority to ideal deceased organ donors, to more urgent transplantation procedures, to difficult transplant recipients, but immediately after that critical situation is overcome, immediately they need to activate everything. And this has allowed the centers to more or less manage and help to compensate one another depending on the epidemiological situation. I will be glad to support India as much as I can in convincing your politicians to make this a solid transplantation program. I'm sure you're able to do it, but as you say, it's very important that politicians and professionals are in the same page.
So we hope to have ongoing guidance from Dr. Beatriz, Dr. Marty, and we hope that we should see you in person in near future with better COVID control. With this, I would like to thank speaker Dr. Beatriz, chairperson Dr. Marty, and with this we conclude this session and for giving mic to the organizer. Thank you.
Thank you once again, speakers
very
and
much,
chairpersons.
Vivek.